Today we'll be discussing about lateral sinus thrombosis. Lateral sinus thrombosis forms about 6% of the intracranial complications of otitis media. So what is lateral sinus? In many of the anatomy textbooks, the transverse sinus is known as a lateral sinus. Some textbooks define transverse sinus plus sigmoid sinus as a lateral sinus. But we all know that sigmoid sinus is a sinus that is closely related to the middle ear. The transverse sinus at the level of tentorium cerebelli continues as a sigmoid sinus in an S-shaped form. That is why it is known as sigmoid sinus, sigmoid S-shape in the mastoid process of the temporal bone. So it is related posterior-medial to the middle ear, and then it continues into the jugular bulb and continues as an internal jugular vein. So the sigmoid sinus can be involved in the middle ear infection or otitis media. So what pathway can cause involvement of sigmoid sinus? Two pathways can cause. First one, there can be bone erosion of bone over the sigmoid sinus by a coalescent mastoiditis or a cholesteatomatous matrix, or there can be thrombophlebitis of the small venules of the sigmoid sinus. In both ways, the infection can spread into the sigmoid sinus. So there can be initially a peri-sinus inflammation and peri-sinus abscess formation, and then there can be involvement of the sinus intima. So the inside of the sinus is involved, and an intimal abscess formation and injury will happen. So we know that whenever an injury happens in a blood vessel, the clotting mechanism is activated. So fibrin is activated. So fibrin, blood cells, platelets, everything adhere to form a thrombus. That is known as a neural thrombus. This neural thrombus will get infected and it can spread proximally to the internal jugular vein and distally to the transverse sinus and into the dural venous sinuses. If it goes to the internal jugular vein, it can go into the right atrium of the heart and cause fulminant septicemia. If it spreads into the dural venous sinuses, it can cause brain abscess. Previously, it was thought that the main causative organism is beta hemolytic streptococci. But now, because the complication is more seen during a chronic otitis media or a chronic infection rather than an acute infection, we get a mixed organism. Can be beta hemolytic streptococcus, staph, coagulase negative staph, and anaerobes like Pseudomonas, Enterococcus, Proteus, etc. Also, certain studies have shown that people who develop this thrombophlebitis have a prothrombotic tendency, that is, they have increased lipoprotein, apolipoprotein, etc. So, what are the clinical features of a lateral sinus thrombosis or a sigmoid sinus thrombosis? The patient can present with high-grade fever. The fever is known as picket fence fever. There will be spikes, 2 or 3 spikes per day, and the fever will not touch baseline. The fever will not come to the normal body temperature. So the spikes corresponds to release of infected thrombus into the bloodstream. Then the patient will be toxic, restless. Patient will have severe otalgia, boring type of ear pain, and ear discharge, which can be foul smelling and blood-stained ear discharge. Patient will have associated headache. Grissinger's sign. What is Grissinger's sign? There is tenderness and edema over the mastoid. This shows that there is thrombosis of the mastoid emissary vein and occlusion of the sigmoid sinus. Then if the thrombus have spread and involved the cavernous sinus, there can be proptosis, ophthalmoplegia, papilledema, ptosis, chemosis, etc. If it is caused by a beta hemolytic streptococci, the patient can have anemia. So patient can have low hemoglobin levels. If the internal jugular vein is involved, it can become hard and cord-like in palpation and also tender to palpate. And also the lymph nodes surrounding internal jugular vein will be enlarged and tender. There are 2 tests that can be done to test for thrombosis in the sigmoid sinus. We do not usually do these tests because we have imaging. What is Dickinson test or Toby-Ayer test? It means that if you compress the internal jugular vein, the pressure is transmitted into CSF. So we have to see if the pressure is transmitted from the internal jugular vein to the CSF. Because internal jugular vein, jugular bulb, sigmoid sinus, transverse sinus, and brain. So we have to see if the pathway is blocked. So what we have to do is we have to do an lumbar puncture. Lumbar puncture is done and the manometer is connected and the normal CSF pressure is recorded. And the increase in pressure is recorded by compression of one side, the other side, and both sides together. So if there is a clot in the sigmoid sinus, when you compress the same side, there will not be an increase in CSF pressure. When you release the compression on the same side, there will not be a drop in the CSF pressure. That is known as a positive Dickinson sign or a positive Toby-Ayer test. So what is the problem with this is there can be false positive. That is, there is no clot, but still the pressure is not transmitted if one of the sigmoid sinus is smaller in size. And also false negative. That is, there is a clot, but the pressure is transmitted. That is when there is a collateral circulation that transmits the pressure. Another test is Crobeck test. In Crobeck test, when you give a pressure over the internal jugular vein, you give pressure of the internal jugular vein and see the eyes using a fundoscope. You can see that there is a dilatation of the retinal veins and papilledema because of blockage of the opposite side. So opposite side is thrombus, so the pressure is not distributed. So if you block this side also, there will be edema of the retinal veins, dilation of the retinal veins and papilledema. So what are the imaging modalities? We have CT and MRI of the temporal bone and brain. So CT, we can see this delta sign. That is because the sigmoid sinus has a thrombus and the blood flow is not there. So contrast enhanced CT shows the thrombus surrounded by a enhancing dural matter. MRI is more sensitive than CT in diagnosing thrombus. In MRI, you can see the blood flow, the sinus obstruction, and if there is any reversal of flow. In gadolinium enhanced MRI also, the delta sign is seen. That is, a thrombus is seen as a soft tissue, and there is a rim of enhancement of the dural wall around the thrombus. Early thrombus is rich in deoxyhemoglobin, so intermediate density on T1 and low intensity on T2. But as the clot matures, it becomes methemoglobin, so it will become hyperintense on both T1 and T2. You can do a blood culture and other routine blood investigations to assess the level of sepsis. What is the treatment? The treatment is broad spectrum IV antibiotics and surgical management. In surgical management, a complete mastectomy is done. The sigmoid sinus is fully exposed. And if there is any perisinus abscess that is drained, we have to palpate the sigmoid sinus. If the sigmoid sinus is soft and pliable, it can be left alone. If a rubbery clot is felt, we can aspirate the clot using a small gauge needle. And if there is no blood flow, you will have to open the sinus and drain the clot. The lateral sinus system is divided into 5 regions. That is the transverse sinus, the sigmoid sinus, the jugular bulb, the internal jugular vein till the confluence of the facial vein. That is upper internal jugular vein and the lower internal jugular vein from the confluence of the facial vein to the confluence of the subclavian vein. So if only one or two is involved, one or two regions are involved, it is known as a limited thrombophlebitis. So, and if more than three or more is involved, it is known as an extensive thrombophlebitis. So in a limited thrombophlebitis, just opening the sinus and evacuation of the clot is enough. Fresh bleeding from the inside part of the sinus is recommended. But if it is an extensive disease, sometimes you will have to resect the sigmoid sinus. Many studies show that just evacuation of the clot using a needle is enough, because once we do a complete mastectomy and remove the disease and the granulation, the sigmoid sinus will recanalize. Certain practices describe ligation of the internal jugular vein prior to evacuation of sigmoid sinus to prevent the clot from spreading into the heart and causing septicemia, but that is not frequently done nowadays. Anticoagulant therapy, whether indicated or not, anticoagulant therapy is not usually recommended for a lateral sinus thrombosis, because in most of the studies and most of the cases show that once you do a surgical treatment and remove the focus of infection, and once you give the patient IV antibiotics, broad spectrum IV antibiotics, the sigmoid sinus will recanalize without any anticoagulants. Anticoagulants are indicated in certain conditions where there are intracranial complications or multiple complications. You have to be careful while you use anticoagulants like enoxaparin or low molecular weight heparin, as there can be chances of venous infarction or hemorrhage. The postoperatively, the antibiotics can be continued for 3 to 4 weeks, and a repeat MRI or MRV can be done to assess the response.